Welcome to the Cure HHT webinar series. I'm Nicole Schaefer, Director of Professional and Medical Programs for Cure HHT, and I want to thank you for joining tonight's webinar, Screening and Treatment of Brain AVMs in HHT. I have just a few reminders. Tonight's call is being recorded and will be posted on our website. After the webinar, you will receive an email with a short survey. Your input is critical to the development of future webinars, so please take a few minutes to answer these survey questions. To help reduce background noise, everyone's phone or microphones are muted tonight, but you can ask questions throughout the webinar by simply going into the gray panel on your screen and typing your question. I will ask as many questions as time allows during the second half of the call. There is also a section for handouts on your control panel. You can download this document to your computer during the webinar, or it will be available on our website and the recorded version of the webinar. And I just ask that you please keep your questions as general as possible and related to today's topic so that the answers will benefit everyone on the call. So before we begin, I'd like to introduce tonight's speaker. Dr. Awad is Director of Neurovascular Surgery, Director of the Safadi Program of Excellence in Clinical and Translational Neuroscience, and Director of the HHT Center of Excellence at the University of Chicago. He earned his medical degree at Loma Linda University School of Medicine, followed by a residency at Cleveland Clinic and fellowships at the Royal Infirmary of Edinburgh and Barrow Neurological Institute. Dr. Awad is skilled in the surgical management of neurovascular conditions affecting the brain and spinal cord, including cerebral aneurysms, cerebrovascular malformations, carotid surgery, hemorrhagic stroke, and skull-base tumors. I now pass today's program over to Dr. Awad.
Thank you, and good evening, everybody, and thank you, Nicole, so much for organizing this. This is an opportunity for us to share information and definitely a better informed patient community is how we start in improving our overall management and health in HHT. So the focus of my webinar this evening is on brain AVMs in HHT, and I will start by presenting general information about how we manage brain AVMs in general, how we screen for them, and what are the options for treatment, and how we decide whether an AVM should or should not be treated. And then we will go specifically into how brain AVMs fit in the disease of hereditary hemorrhagic telangiectasia and why it is important to screen for them. I'm going to try to keep the talk very quick and not lingering on any of the information so that we can leave a lot of time for questions and answers. Obviously, some of the information is more technical, and some people may be more aware of it than others. So you can later go slowly over the webinar and maybe linger a little bit longer on some of the slides. So I really have no conflicts of interest regarding this talk. I receive funding from the National Institutes of Health, and I have various unpaid board positions. So the idea of a center of excellence for rare diseases like HHT, and I also run a center of excellence for cavernous angiomas, is to be able to bring information to the community about guidelines-driven care, and be able to have this very uncommon and complex disease under the management of a team that is familiar with it. So we do not want you to go to a doctor that doesn't know much about AVM or HHT, we want you connected with specialists who really know about the disease and about the particular disease manifestations. So the idea is to facilitate complex care through experience and to bring to you the latest innovation and access to research. And the key to these centers of excellence is our clinical coordinators. So the clinical coordinator for my HHT center in Chicago is Zina Darji, and Zina is a very experienced and caring nurse who will basically be the contact person with you as we gather all the information before I meet you personally if you are receiving care at our center. So neurovascular, or the problems of blood vessels of the brain, include a huge complex group of pathologies and also many different types of doctors who work together as a team in managing these problems. So we have surgeons, we have endovascular doctors, we have neurologists, and many other specialists. And we also have research teams. And these research teams are extremely important because they help run clinical trials, and they also do disease research in the laboratory. The first thing to understand about vascular malformations is the appearance of a vascular malformation can help us understand what type it is. And the names can be confusing. And I do not want you to confuse the term venous or arteriovenous or cavernous, because these malformations, although they sound the same, are actually very different. And like you see here on this slide, their appearance in the brain is very different, the way they bleed is different, and so forth. So the types of vascular malformation that arise in HHT are arteriovenous malformations. Just like you have AVMs or may have AVMs in the lung or in the lips or on the skin or in the GI tract or liver, the brain would have an AVM. And the AVM, I'm trying to get here here we go. So this is an AVM in contrast to these other types of vascular malformations. And the AVM is a direct connection between the arteries and the veins. So the arteries and the veins are interconnected without the usual capillary bed that slows the blood down. So this nest of blood vessels is made up of arteries and veins in direct communication, which means the veins are under arterial pressure. So these become veins that are stressed out under high blood pressure, not the normal slow pressure that a vein has. And as a result of that, these are called high flow lesions, where they have multiple arteries supplying them. Some of the arteries may have aneurysms on them, and then the veins themselves are dilated and stressed by arteriovenous shunting. So unlike the lung, where the arteriovenous shunting serves as a problem to get clots to the other side, so we worry about the pulmonary AVM causing embolism or a clot to go from the artery to the vein and then travel to the brain and so forth. In the brain, that's not the issue. The AVMs are very small. They're usually about from the size of a pea to the size of maybe larger than in an almond, like this one is. And the main worry about these AVMs is their irritation of the brain to cause seizures, or more seriously, if they burst and cause a bleed in the brain, then you're not going to leak blood from the nose or from the GI tract. If you bleed in the brain, you get a stroke. So that's not a good thing. So the one thing to understand is that AVMs develop over time and they draw feeders into them. So this is an area of arteriovenous shunting that is drawing vessels from different parts of the skull and scalp to feed this AVM. This is one that is drawing blood supply from the other side, and therefore arteriovenous shunting causes a local ischemia and activation of these angiogenic factors that draw new feeders into this AVM. So this is not something that is easy to deal with, because the minute you touch any of these things, it starts to bleed because it is filled with this high flow system and many different feeders going into it. So when we have an AVM in the brain, it's a scary thing. So of course we are afraid of the risk of bleeding, which is a form of stroke, hemorrhagic stroke or bleeding in the brain, or the risk of seizures. So these are the things that an AVM does. So the first thing we have to discuss with the patient is what is the natural history estimate, meaning what is the likelihood that this AVM in your brain at your age is gonna cause bleeding or seizures. Because if that risk is very low, then you don't want to use a treatment that is very risky. Because if the risk of the treatment is worse than the risk of the lesion, that's not a very good idea. So you only want to treat it if the treatment risk is lower than the risk of the lesion. So we lay out a number of treatment options or therapeutic options and goals and estimate the risks. And therefore, with you and the doctor together, you can make individual considerations as to whether you're going to have this treatment or that treatment. So do not get confused when you go on Wikipedia or ask your cousin about their AVM. Each AVM is different and each patient is different. And what treatment is good for one AVM may not be good for another. So what do I mean by that? Let's go over how we estimate natural history risk and also what are the different treatments we can deploy. So this is an angiogram test that shows the arteries feeding the AVM, and this is the nest of the AVM. On MRI, we can see these AVMs. So usually the test is to screen with an MRI, and if we see something that looks like an AVM, we start the discussion about treating it, and if we're going to treat it, then we do this angiogram test in conjunction with the treatment. So the most important thing to do is do not rush to have treatment. In fact, a big study was done and was published in 2014. It's easy to remember it. It's called the Aruba Trial, Aruba Trial, and it randomized half the patients to receive the treatment that their doctor offered for them versus the other half of the patients whose AVM never bled before. So this is an AVM discovered by chance or causing seizures, but never bled before. So half the patients got the treatment that their doctor recommended, and the other half continued to watch the lesion. So as a whole, in this whole trial, the people who had the treatment had so many complications from the treatment that up to 5 years out, they were worse off than the people who had their AVM watched. So it is not a foregone conclusion that you've got to remove the AVM or treat it or cure it. Sometimes it may be better to watch it. Now, these were not selected patients that have high-risk AVMs, and that received the best treatment. This was a combination of all possible treatments versus AVMs that never bled with up to 5 years of follow-up. Now, also, most of us live longer than 5 years, so even these results could justify treatment up front if the person's life expectancy is very long, so that you can take a chance up front with the treatment, and then your AVM never does anything bad after that. While if you don't have treatment, then over time the AVM can cause problems. So this is how we look at it in quality of life. So quality of life is 1 when you are doing everything you possibly want to do, and it's 0 if you are disabled and dependent on others. And if you start with a quality of life of 1, then discover you have an AVM, you have an option. You either have a treatment, and that itself can affect your quality of life, but then you recover over time, or you can wait and maybe the AVM will bleed, and then that hurts you more and maybe never recover. So it is important to really look at the outlook over your lifetime and have very accurate estimates of what is the treatment risk and what is the risk of the AVM. Because if the AVM ain't gonna do nothing, then this is bad. If the treatment is worse than the risk of the AVM, then that's also very bad. So the first thing to know is that there are risk modifiers with the AVMs, particularly if lesions are deep in the brain, not on the surface of the brain. They have odds ratios of 5 times more likely to bleed. And if it has a deep vein coming out of it, also the odds ratio is 3 times more. And if the AVM has bled previously, like has hemorrhaged, the odds ratio is 5 times more, at least in the first couple of years after the bleed. So if you take all of these modifiers, then we maybe have a situation where some AVMs who are superficial, never bled, and have no deep drainage, the risk of bleeding is less than 1% per year. So you cannot throw the kitchen sink at this AVM. You got to either watch this AVM or treat it with an equally low risk. However, if an AVM has bled before, the risk becomes as high as 14 or 15%. And if it bled before and it is deep in the brain, the risk is like a ticking time bomb, 35% risk. Therefore, trying to understand whether your lesion is this or this or this is extremely important as to your decision whether to have treatment or not. So when we look at the types of treatments, there are 3 different treatments that are offered for brain AVM. Microsurgery, which is to remove the lesion, radiosurgery, which is to radiate the lesion with focused beams, and embolization, which is to go up with a catheter and try to clog up the AVM with glue. So in the pulmonary AVMs, we treat them always with embolization, and the risk is always very low and very effective treatment. But look, in brain AVMs, the risk of a permanent neurologic deficit is about 6% after treatment with embolization, and it doesn't cure the AVM. Only 13%, 1 out of 6, gets cured by embolization. So you have to select very specific lesions for embolization, or use the embolization to prepare the lesion to be finished off with radiosurgery or microsurgery. Now, radiation has also some risk, but it has a higher chance of curing the lesion, 38%, but if we select it correctly, it can be as high as 75% for small AVMs like the ones with HHT patients. And the microsurgery, the risks are 7.4%. So they are not insignificant, and they can vary a great deal from 0 to 40% risk. And I will tell you what determines whether the risk of surgery is this high or this high. So basically, the grade of the AVM, whether the AVM is small, medium, and large, whether it is in an important part of the brain controlling speech or motor function or not, and whether it is deep or not in its supply, those determine the grade of the AVM. And look at this. If the grade is very low, it's a surgical chip shot. You can take it out at very low risk, nearly zero risk. But if the lesion is large in an important part of the brain and has deep venous drainage, the risks are prohibitive. Major neurologic deficits and higher risk of minor neurologic deficits. So again, not all AVMs are created equal. So I'm going to show you now an example of an AVM where we decided to do a very risky procedure because the AVM was a ticking time bomb. So this is a tiny AVM, exactly like those most people with HHT have. It's a very small AVM, but it already bled in the brain. It caused the hemorrhage. And that hemorrhage was in an important part in the stem, the brain stem of the brain. So the patient was debilitated, had left-sided weakness, and was in a coma for several days. And then the worst thing this patient could have, who was a very young patient in his 20s, was to leave this AVM untreated because it had a very, very high risk of rebleeding. Why? Because it is deep, has deep venous drainage, and has already bled. I already told you these AVMs have about a 35% chance of rebleeding. That's a very, very high risk. That's per year. So over 2 to 3 years, it's 100% chance that it will bleed. So basically, what we said here is that the risk of rebleed is very high with dire consequences in the brainstem. Therefore, you can't leave this lesion alone. Now, embolization could not be done because of where it is. You cannot reach it with embolization catheter. Radiosurgery, although it has a high cure rate, it takes 2 years for the AVM to cure after radiation. And the problem with waiting 2 years on this young man is this: there is 50% chance he would rebleed within 2 years. So it is very important then to do the microsurgery, even though it is in a tough spot with a 10% serious risk of the procedure. So this is what it looked like when we did it. You could see the artery here, the vein here having artery blood. You see with the heartbeat, that vein has this bright red blood. And then we worked very, very slowly for several hours, peeling this AVM away from the stem of the brain, and then eventually you will see it is taken out. Here you go. So embolization, as I said, it has a low rate of cure, and it can have serious complications, and it must be deployed very carefully with a particular aim, either to prepare the lesion for surgery or if it has a very high chance of curing the lesion. This is a patient who had an AVM that was in this area here. Now it is filled with glue. They saw me and I told them, do not have this embolized. This is not a good idea, and this lesion should be watched or radiated because the risk of surgery and embolization is too high. They did not listen. They went to another doctor in town who did the embolization, and the night after the embolization, the lesion ruptured because they couldn't finish it off completely with the embolization. So they destabilized it and caused this big hemorrhage. and that doctor did not want to operate on it. So the patient was transferred emergently to our center, and we saved the patient's life by removing the blood clot. But what a mess. The patient ended up paralyzed from a procedure that we knew ahead of time had a very low chance of curing the AVM without dire consequence. Radiation is very attractive. We use it all the time for HHT AVMs because radiation can be done from the outside without going to sleep, without doing an incision, and it is basically the convergent beams of radiation that will converge on the AVM, and the AVM will receive the dose. And the complications of radiosurgery are nearly in the same range as those of surgery, but it can reach deep parts of the brain without having to take the risks of surgery. And just think of it, you don't even have to come to the hospital or have anesthesia or have a wound. So it is a very attractive treatment. The only problem is that we can only do it if we can only help the AVM if we can give a very high dose in that part of the brain. So the AVM has to be quite small. If the AVM is very large, the risk of giving the radiation can become very high. And the other problem is that it takes about 2 years, 1.5 to 3 years, from the day you get the radiation, which is a single dose. You can call it gamma knife or cyber knife or LINAC. They all do the same thing. It takes about 2 years from the day of treatment till the AVM goes away. So if that AVM is bleeding, you cannot wait the 2 years. So these are various AVMs that we targeted with radiation, and you could see the dose of radiation is right on the AVM, then it goes down lower and lower beyond the AVM, so the normal brain receives very little radiation. And some big lesions we can divide in half and do 2 radiation doses. This is an 11-year-old boy giving the thumb up. This is what the treatment looks like. So we put the patient's head in a mask, and you can breathe through the mask, and you lay down on the table with the head fixed for about half an hour till we complete the procedure. The mask is important because it prevents your head from moving, so the radiation can hit the right spot, but also it is a reference for the machine, so the machine knows what to radiate and how to deliver those beams. So the machine will turn over time, over the half an hour, till the treatment is completed. You don't feel anything during the treatment at all. So the team dynamics are very important. You need the captain of the ship who really knows the AVM. Don't go doctor hopping. Don't go to one person that does only one type of thing, only catheters or only radiation. You need to go to a team that does everything, and then try to have a goal for the treatment and cut out the redundant steps. I get so many patients that had partial treatments or angiograms done for no reason, and the cost and the morbidity of these redundant steps are way, way too great and so unnecessary. So to complete my part of the presentation, I want to just go a little bit over how brain AVMs are different in HHT. So the most important thing is, of course, they occur with a family history of HHT in patients who have nosebleeds, and the most important thing is that if we find more than one AVM in the brain, this patient has 6, 1, 2, 3, 4, 5, 6, then it is almost always HHT. There are no other diseases that are well known that form multiple brain AVMs. So if a person has multiple brain AVMs, they usually have HHT. Consequently, when we do studies for HHT patients, they have about 1 to 9 AVMs. So the most we've seen in a patient is 9 AVMs. The least, of course, is 1. typically the median is about 1 to 3 AVMs. So most patients who are going to have an AVM, they either have 1, 2, or 3, but they can have as many as these multiple AVMs. They're usually small, but some of them can get big with some ugly features like an aneurysm. So this one becomes a critical target for early treatment because of the aneurysm. These can be treated with radiation and can scar over time. In all, about 1 in 4 to 1 in 6 patients with HHT may have a brain AVM, and we screen for them with MRI and MRA, and if there is a question about an AVM, then we do this test, which is the angiogram. Now, of course, you all know that you have other AVMs throughout the body, but what you may not have known is that every little dot on your skin, on your tongue, on your lip is also an AVM. These are not like little angiomas or telangiectasia. They really are micro AVMs. So the word hereditary hemorrhagic telangiectasia, if we know today to name the disease, we will call it hereditary hemorrhagic multiple AVMs, because every little lesion is an AVM. And of course, the pulmonary one is very important. This is a pulmonary AVM on a chest CAT scan. This does not usually bleed like the brain AVM, but it acts as a shunt of blood. Instead of the blood being filtered by the lung, there is no filtering mechanism, and the blood goes from the pulmonary vein back to the heart without really being filtered, and therefore it can go up to the brain and the other circulation. So the most common neurologic problem in HHT is a stroke from a pulmonary AVM, and the next neurologic problem is a brain abscess from a pulmonary AVM. The third one is a brain AVM. So it's not all about brain AVMs. You can have strokes from the pulmonary AVMs as well. Even the skin lesions, when we study them on biopsy, they are little micro AVMs with all the same features as the brain or the lung AVM. Now, we know that there are now 3 definite gene loci and maybe other rare gene loci for HHT. These others cause HHT-like illnesses, but it's very important when we talk to you about doing the genetic testing so we know what it is, because if you have the typical ones, the endoglin and activin, these are fairly simple, and we have to screen for brain and pulmonary and GI AVMs. That's enough. But if you had this one on 18q, that becomes a Marfan's disease with risk for other complications like aortic aneurysms and other problems. And some of you have heard of the SMADA4 gene, which is HHT3, and this can cause juvenile polyposis. So people will have not only gut AVMs, but they can also have polyps in the gut, and the polyps can cause colon cancer. So if we know what gene you have, we know you have the SMADA, then we're going to be watching you very closely for any precancerous polyps in your gut, while this would not be the case with these genes. And if you have this gene, we'd be watching you for aortic aneurysms as well. So these are the complex mechanisms that can cause TGF-beta signaling and an AVM to form. But what's important is also the lesion progression. This is why we have not been able to develop a drug that inhibits TGF-beta signaling, because it is so essential to life, TGF-beta signaling. You can't just shut down that signaling. And if you did, you wouldn't cure the AVMs that already formed. So if you already have some AVMs in your body, you're not going to treat them with this. But we may be able to treat them with anti-angiogenesis drugs, the drugs that prevent the maintenance of the AVM. So that once the AVM forms, it can scar away if it doesn't have constant supply from new feeders, and these new feeders are supplied by angiogenesis. So this is why we're using drugs like Avastin in the nose, or Avastin as IV injections to try to make the AVMs regress. So this was my presentation, and I hope I gave you a very good generalized view about AVMs. Other than the questions we're going to answer today, if you think you have HHT or a brain AVM, please contact us. This is our website, and we are happy. We have a clinical coordinator who will get back to you, try to understand your case, and see if we can help you. Thank you very much.
Thank you so much, Dr. Awad. I appreciate that very thorough overview of brain AVMs and HHT. And we do actually have quite a few questions, so we will get started with those. So the first question says, the annual bleed rate is estimated to be 2 to 4% per year for non-HHT patients, but much lower, below 1% for HHT patients. And their person is wondering if you agree with these figures based on your experience, and would ask if you could explain why there is such a significant difference.
Yeah, so the difference is not surprising. It has to do with the type of AVMs most patients with HHT have, which are usually very tiny and very superficial and have not bled yet. So if I told you about that group of AVMs, I already told you that group has less than 1% per year. So you didn't need to be quizzing it. So there is that group of AVM. But if you happen to have an AVM that has deep drainage or has hemorrhaged already, then that risk can be as high as 30% per year. So beware of these averages, whether the 1% or the 2 to 4%, they mean nothing. They are all the AVMs in the world. But what you need to worry about is your AVM. What is the risk in my AVM? So whether it's HHT or non-HHT, the most AVMs in HHT are small, tiny, superficial. Therefore, they have a lower risk. Therefore, we don't rush to surgery. We either treat them with radiation or watch them. But if they have other features, or if they change, or if they bleed, they are not under 1%.
Okay, and several of our questions relate to pediatric patients. Does the University of Chicago treat pediatric patients with brain AVMs?
Definitely. So the way I treat pediatric patients, I treat pediatric patients at all ages, so does my team, is in collaboration with the pediatric neurosurgeon and the pediatric team, and including pediatric anesthesiologists, but also with the full expertise of the neurovascular team. So basically, the patient as a whole is being taken care of by the kids' doctors, but we don't let the kids' neurosurgeon remove the AVM because I don't know much about AVMs. So we have the vascular people take care of the AVM in the child, working as a team. So that's how we handle it. The risk in children of an AVM for any given year is very similar to the risk in an adult with that same AVM. Again, small, large, shallow, or deep. However, the difference with the child is that the child has many more years to live with the AVM than a 60-year-old or a 50-year-old patient. Therefore, their natural risk from that AVM, however small per year, can add up over a long lifetime. While you could take a gamble if you're 60 years old and have a tiny AVM, that it may not do anything in your lifetime.
Right, okay. So the next question is asking what, specific to the University of Chicago, what is your approach to the treatment of asymptomatic or small AVMs that are grade 1 or 2? And are you
Yes.
typically aggressive with treating or passive with watching, and why?
So this was my talk. I think, I went over it. I'm not going to repeat the talk. So basically, we look at each lesion. We try to see whether it has any features that make it more dangerous or less dangerous. We look at the patient and what life span they are looking at, and also at the risk tolerance. I can sit with a patient who has the same AVM and who wants to have it watched if the risk is very tiny, and another person is so nervous they absolutely want it treated. So we work with you on whatever treatment is best for you, giving you the data to make the best decision with us. I hope that helps.
Okay, thank you. So we have a question asking, are bleeds and ruptures the same thing?
Yes.
Okay. And is minor bleeding or seeping more common than full-blown ruptures?
So for other vascular malformations like cavernous angiomas, they do a lot of passive minor leak. But irregular AVM in the brain, even if it bled small, it can be very, very dangerous. So if it bled small, that means you're lucky. Okay. So most of bleeds from AVM are serious high flow bleeds, and they can be fatal. And therefore, if an AVM bled, this is a big red flag to have it treated. And I hope that message came across in my talk, that once an AVM bleeds, it goes into a different range of risk.
Okay. So the next question says, is the vein of Galen aneurysm, which is seen in a fetus, caused by HHT?
Yeah, so the vein of Galen aneurysm is a type of AVM where the drainage is through the vein of Galen that becomes a big aneurysm, so in the depth of the brain. These are found in the fetus. I have seen them as part of the HHT AVMs, but much, much more commonly, they have nothing to do with HHT. And they have to be treated based on their own consideration.
Okay. And so we have a couple of questions just relating to the screening protocols for brain AVMs. Someone has been told they need to be screened every year. Someone has been told every 5 years. And so could you just maybe go over that both for an adult and for a child?
Yes. So obviously the rationale of screening has to do with how fast does a new AVM form if your first MRI was negative, right? That's what screening is. So you have the first MRI. If you have an AVM, then you're going to deal with that. But then the question is, if you don't have an AVM, or if you cured the AVM you found, what's the chance I'm going to find another one? How often do I have to be retested? So AVMs in the brain do not form as quickly as those in the lungs. So our guidelines call for screening for lung AVMs every 5 years if your lung AVM scan is negative, screen is negative, and for the brain every 10 years if it is negative. So for a child, we do the first one as soon as they can have a scan without anesthesia. We do not think that the risk of putting a child to sleep at the age of 2 or 1 is worth it to find an AVM that's asymptomatic, because you want to wait till they're a little bit older to treat an asymptomatic AVM anyway. Now, if it is symptomatic, we do the test at any age. But screening is for asymptomatic patients, meaning the kid is growing up, They just have a mutation for HHT. And if that's the only thing, then we do the first MRI when they can have it without anesthesia at about age 7 or 8 with some light sedation. And then after that in their teens before they go to college. And then every 10 years, if it's negative. If it's negative.
Okay.
If it's positive and you're following it, then that's not screening anymore. That is called surveillance. And surveillance of a known AVM should be done much more closely. So that's where the every year comes up. I don't really know any doctor that knows anything about AVMs or HHT that tells you you need to be screened every year. You must be using screening with surveillance. So surveillance means you already know an AVM and you are keeping an eye on it. That ought to be done about every year.
Okay. And is there evidence that AVMs develop later in life if you do have a negative screening?
Yes, they can develop, and they develop at a very low rate. Therefore, doing scans more often than every 10 years is futile if your first scan is negative. So just getting hyper about it and doing one every year doesn't make it safer.
Right. Okay.
So yeah, they can form, but the rate is low enough that you know, less than 1% per year. Therefore, you know, waiting 10 years is a very good compromise.
Okay. So we have a question asking, and you may have touched on this, but I guess just wanting a little bit more clarification on the difference between a brain aneurysm and a brain AVM.
So an aneurysm is a weakness in the blood vessel wall. Most aneurysms have no AVMs with them, and they have nothing to do with HHT. It's a different disease. However, an AVM can grow an aneurysm on it because of the high flow. So you may hear, I have an AVM with an aneurysm on it, or on an artery leading to it. That can happen with HHT, and that can be pretty serious because the aneurysm may be as serious as the AVM and needs to be fixed.
Okay.
But if, you know, if you had a grandma who had a brain AVM or a cousin who had a brain AVM and you have an aneurysm, that doesn't mean you have the same disease.
Right. Okay. So we have someone asking, what would symptoms of a brain AVM be for someone who maybe hasn't been screened in either a child or an adult? Are there physical symptoms?
Yeah, so the most common symptom is a seizure or a bleed, which are the symptoms we worry about, right? That's why we do screening even in asymptomatic patient, because we want to catch those before they happen. So bleeding, you don't want to wait till it happens, but bleeding can cause weakness in the arm or leg, a stroke, basically. A seizure can happen from an AVM, and the seizure is like scarier than it really is, because often if you have a seizure and an AVM, you just take a medicine that controls the seizures, and you deal with the AVM on its own right. Is that AVM worth removing or not removing? What are the risks? But the epilepsy or the seizures can be controlled with medications. The same is true for headaches. Some people can have headaches, and then they get an MRI, and they find an AVM. Now, did the AVM cause the headache, or did the headache just cause the MRI? You know, so we'll never really know for sure. And many people start to worry, I have a headache and an AVM, therefore the AVM must be the problem. Again, you need to meet with some fairly sophisticated doctors that can tell you whether your headache is related to the AVM or not. But certainly in a child who has headaches. Children are not supposed to have headaches. If they have a family history of HHT, then we should do the MRI sooner rather than later.
Okay, very good. So the next question asks, what follow-up is needed after treating a brain AVM?
The very, very good question. So if you are a child and the AVM is treated before your teen years, even if it is cured, there is a chance it might come back when you're an adult. So for pediatric AVMs, it's always important to repeat an MRI, MRA about 10 years later in your early adult life to make sure it's not coming back. But I already told you that for HHT, we do screening every 10 years. So we'll catch it if it came back. And we'll also catch if any new ones form, because HHT patients get new ones. However, if you're an adult that had an AVM treated, that AVM will never come back if it was cured, truly cured. But don't, just like to believe that it was cured. 90% cured is not cured. It's like being 90% pregnant. You either have an AVM that fills or the AVM no longer fills. If the AVM no longer fills in an adult, that AVM will not come back. We'll still screen you every 10 years for new ones elsewhere in the brain because HHT patients get them. But if you didn't have HHT and had a brain AVM that's cured in adulthood, you need no further screening.
Okay. Excellent. So we have a question that asks if you have seen an AVM in the brain heal itself. So I'm thinking they mean disappear.
Yes. So there is such a thing as spontaneous obliteration. It is a very rare event, and it happens, in the order of maybe 1 in 4,000 or 5,000. Therefore, if that happens, you just keep your eye, make sure it's not, you didn't get like a suboptimal MRI or a bad test and so forth. So I'd really have to test that before we make sure we believe it. It's almost as rare and as great as a miracle, but I wouldn't bet on one.
Okay. Now an individual is asking, if you have liver AVMs, is the risk higher for brain or pulmonary AVMs?
Not at all. So liver AVMs actually can happen in a lot of patients with HHT. The problem is that there is nothing to do for them unless they are causing liver failure or venoportal hypertension or other things. So therefore, I don't in my practice screen for liver AVMs except through a blood test for your liver function test. So if your liver function is good, I don't care if you have an AVM in your liver. It's not going to do anything unless the liver function is affected.
Okay.
But they have no relationship to brain and pulmonary AVM. You still need to screen for those, whether you have a liver AVM or not.
Okay. And we have a question asking really about genetic testing and if how old is too old to get genetic testing, but I think it's a good point for trying to talk about the asymptomatic children and brain AVMs, and really it is a way to identify family members that may not have HHT symptoms. So do you mind talking just for a second about the genetic testing?
So before I go there, I want each one of you who have had HHT to remember how old you were when you first found out. So many people didn't find out till they were in their teens or 20s, or they had the first nosebleed at age 12 or 14. So what if you had a brain AVM that was a real bad one, or a pulmonary AVM that could be causing a stroke, and you just didn't know? And it's very tragic when I see a 10 or 12-year-old with a stroke from a pulmonary AVM, while their parents has HHT, and they never screened them. So it is important to screen asymptomatic patients with HHT. Now, how do you know you have HHT? If you're asymptomatic, you get the genetic test. This is the beauty of this disease. If the genetic test is negative, you don't have HHT. So let's say your mom has HHT and has the endoglin mutation. You only need to be tested for the endoglin mutation, because you're not going to catch somebody else's HHT. It's not going to be caught in the milk from the milkman. You're going to get it from your mother. So that mother with the endoglin, you screen for endoglin. If you don't have it, then you know you carry the disease, and you may be hiding a brain AVM or a pulmonary AVM. But if you screen negative, then your mom didn't pass that gene to you, and therefore you will never get HHT in your life. You will never get an AVM in your life, and none of your kids will. Wouldn't that be beautiful, to free our children from the worry of HHT if we have HHT in our family? So that's why every family with HHT, somebody in the family needs to go through the genetic testing so we know what mutation it is, and the rest of the family members who are unaffected can at least screen for this gene to know if they carry it or not. Of course, if they have nosebleeds and the lip lesions, they don't need the genetic test to know that they got their mother's mutation. But if it's a kid, if it's a kid and hasn't yet had symptoms, the only way is to do the genetic testing. You asked me how old. I'm going to answer the other question. I'm going to say how young. I think the children should get their HHT test for their mother or father's mutation on the umbilical vein when they are born, before they leave the hospital. So if you know you have HHT and you or your wife are having a baby, you can test the baby while they're in the hospital before they go home from the umbilical vein without even sticking them. And then you'll have the answer within a week or two. And then that kid has 50% chance of never ever worrying about this problem. Or if they have the problem, then at least you put a plan for dealing with it later on in their life. How old you are for getting tested? If you have the triad, the clinical symptoms, you don't need genetic testing for yourself. We need to screen you for pulmonary and brain AVMs. But we may ask you for a genetic test for the sake of the rest of your family.
That's great. Thank you so much. So we have just a couple more questions, and then we'll wrap up. So this one says, if a child has HHT and is screened for brain AVMs and is found to have a developmental venous anomaly, are there concerns that the DVA will turn into a brain AVM? And if so, what would be the next recommended steps?
Yeah, so a DVA, or developmental venous anomaly, I showed a picture of it early in the talk, is very benign. And when we recognize them, we don't do anything for them, and they do not form AVMs. But my only caution for the people who ask the question is make sure whoever is calling it a DVA knows the hell what they're talking about. Because an AVM can look like a DVA. So you have to have a highly expert team. So I would seek a second opinion from a neurovascular specialist who does brain AVMs to be able to tell, if you have HHT, I mean, to be able to tell you if that lesion on MRI is really not an AVM. Sometimes we do an angiogram to really be sure it is that questionable. Because an AVM can have a draining vein, and the radiologists are too quick to call it a developmental venous anomaly when they don't see too many of these.
Okay. And again, through the Cure HHT Foundation, I mean, we always strongly recommend that everyone go to an HHT center because of the coordinated care that they receive there from a variety of specialists. but also because you do see HHT every day, and it is misdiagnosed all the time, because things in HHT can look like something else. So, I mean, I definitely agree that even if it's just that one time for that initial screening, and then the follow-up care that happens every 5 or 10 years or whatever, just really be done at an HHT center for that very reason.
I totally agree with that. It's one thing to walk into a doctor's office who's never seen this problem or dealt with it on a regular basis versus going to the teams that deal with this all the time.
Right. And so then our last question will be, are patients who've had previous stroke due to brain AVM at any increased risk of a bleed from a new AVM?
Yeah, so that's a complicated question because we have to be sure that the stroke was caused by an AVM, the first stroke, right? So was it a stroke from a pulmonary AVM? Was it a stroke from another cause? If it was caused from a brain AVM and they happen to have other AVMs in their brain, I would watch those AVMs very closely because there may be something about that patient's bleeding tendency from AVMs that their AVM could be more dangerous.
Right. Okay. Well, great. Thank you so much. I mean, you have been extremely informative and very helpful. And I know you've provided your contact information for everybody. If there's any additional questions, we would definitely recommend that if you live in the Chicago area, surrounding cities, or want to go there for a visit, that is definitely a great HHT center to see if you have a brain AVM in particular. So in closing, for tonight, I just want to say that all of us here at Cure HHT want to thank you for attending tonight's webinar. Our shared goal is to advance one common hope and to give those affected by HHT a chance for a normal life. And I want to make you aware that the Brain AVM study is going on. This is an information gathering study. There are HHT centers of excellence that are recruiting for the study, but the majority of our centers are not recruiting for that study. So if you or a family member have either a genetic or clinical diagnosis of HHT, and you have a diagnosis of a brain AVM, whether it's been treated or not, and you're willing to participate in this brain AVM study or to learn more about it, I recommend that you contact our office at 410-357-9932 for more information. Cure HHT is a recruiting center for that study for patients that are not being recruited at one of the participating HHT centers. This webinar series is just one of many ways we accomplish our mission, and we're so grateful to the donors of Cure HHT for making this and all webinars possible. Please consider donating to Cure HHT to ensure that we continue to offer high-quality education for you and your families. And don't forget that after the webinar, when you receive your short survey, to please take a few minutes to complete it so we can better serve you in the future. Again, I want to thank Dr. Awad for volunteering his time tonight to lead this webinar and for treating HHT patients in the Chicago area and around the country. This webinar has been recorded and will be posted on our website at www.curehht.org in our resource library. We truly appreciate your participation tonight, and we hope you enjoy the rest of your evening. Thank you.